everybody. It's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS Airway Management. All right, so stay tuned for this installment of EMS Airways.
I'll start with King.
You start with King? Sure.
I'll open with King. I don't want to steal anybody's iGel thunder, so I'll talk about King.
There's no stealing thunder.
So there are some pediatric sizes. The iGel, to my knowledge and understanding, does offer more pediatric iGel sizes. Sure. You really didn't see these gain pediatric popularity, in my opinion, until COVID. Like, we didn't even carry pediatric Kings on our apparatus until COVID hit, and then it was like, oh my God, we have to have these, so we bought them. They are height-based, so the typical sizes that you're going to see for an adult is going to be a 3, 4, 5. I actually teach how to size it in reverse. So if I'm going to utilize a King 5, that means they are 6 feet or greater. So if they're hanging off your cot, or they're as tall or taller than a backboard, then they're 6 feet, they get a 5. Moving down the next step, if you want to move to a King 4, which I'm holding, that's going to be your 5 to 6 foot range. And then if you move to the 3, that's going to be your 4 to 5 foot range. 4 is obviously the most common. It's a maroon color. Most of these are sold in whatever type of kit you purchase, but it's going to come with a 60cc syringe. It's going to come with the King Airway size and then typically some sort of lubricant to utilize it. Mm-hmm. I do always tell everybody to memorize the sizes of them, but you do not need to memorize the air volume that goes in any of them. Because it's all listed on the side of the tube, how many mLs of air. Most of them range from 60 to 80. Do you want to get into some of the challenges with this and placement?
Pros and cons, absolutely.
So one of the cons, in my opinion, obviously it's a blind insertion. We can insert the device into the patient and inflate both the distal and the proximal cuffs. They inflate at once. And the main issue with these is once you connect your BVM and you're utilizing capnography and you start to bag your patient and you're not having good chest rise and fall, it's probably a seat problem. You might need to actually pull back on that tube just a little bit as you're bagging, just because of these balloons are not seated in the correct position or where they need to be so you can properly ventilate their patient. That's probably one of my only big bugaboos with this airway when compared to like the iGel. Yep. Unless somebody else has.
Nope, I want to expand on that a little bit. So, let's think about what we're doing is, let's say my airway's here, my esophagus is here, right? Here's my epiglottis. Mm-hmm. So as I'm running this device is intended to follow the path of the oropharynx and wind up in the esophagus. The tip of this device is sitting in the esophagus, right? And this distal cuff is blocking the esophagus. This is larger cuff, this lower volume, this larger cuff is blocking the oropharynx, pointing.
You can see it when you do this.
Pointing those holes at the trachea, right? So as we run that down, we're running it past the epiglottis and rolling it down. So there's even anatomical benefit to doing exactly what you said, is right, is pull back a little bit. Now there's some cautionary tale here, right?
Correct.
So I've got this cuff blow up down here, and this other cuff starts to blow up back here. Well, what it does is it actually kind of helps rake that epiglottis open. Yep. Now, the problem is when you pull too far, right? Is when you pull it out too far. All right. Now I've got this big inflated bulb up here, right? If instinctively, what do? Shove it down, right?
Yep.
I shoved it in and it worked.
I pulled it back too far.
I pulled it back, and it pops out, and now you're, it's all the air is rushing out of the oropharynx. Instinctively, what do? You push it down, right? But what that does is that takes that epiglottis, and here's that big bulb that's still inflating, and it makes an airway obstruction, right? Or it can make an airway obstruction.
Well, that's what the epiglottis is there designed to do, right?
You are solidifying its job.
It's doing its job, right? You had one job, and you're doing it. But building off of that, if you do pull it back, restate it slightly, bury it, pull it back until you get optimal rise and fall of chest.
And then stop.
Come on, it's going to happen, right? When you pull it too far and it pops out, and now you're getting air out of the oropharynx, deflate the cuff, reseat it, and then start over, or else you're running on essentially.
Yes.
Occluding the airway. other little tidbit that I have found is these are nitrile. These are nitrile cuffs, right? Anybody here ever put a nitrile glove on and ripped it?
Yeah.
Every other glove.
Giggle, 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 ha ha. Well, you should stop trying to put small gloves on your bear paws there, buddy. But
If it doesn't fit, you must quit.
I've seen people get a little aggressive, run these across the teeth, and then you nick and there's basically it's done. Right? You throw it away. You said you teach backwards, basically
Sizing. Just for
you're sizing six,
Yes.
6 foot and bigger gets the biggest one. I have kind of broken it down to 3, 4, 5 is small adult, regular adult, large adult, and turns out that also works with eye gels, right?
Yeah.
So, are you an average size human, or are you a small in stature human? Then I'm probably going to start in the 3.
Right.
Everybody in this room gets we could make a 4 fit everybody in this room. One of us could probably also take a 5, right?
Well, and that's the one benefit of iGel is that it's a lot of. This right here is 50 to 90 kilograms, which is a wide range of.
And there's overlap between the two.
Yeah, absolutely.
There is, absolutely, yeah. But those would be my pieces of input for this. At this point, nobody should have. There was 2 versions of the King. There was one with and without the suction channel.
Yeah.
And those are all channeled over there. So I think they did away with the non-channeled version.
I believe so.
Yeah. So all you have is you can run a suction catheter down here to decompress the stomach. If you're using OGs and NG tube, you can decompress.
It's actually amazing how many people don't know that.
Yeah, you can run that down to decompress the stomach. If you've got somebody with a full belly, I'm sure everybody has had the experience of putting a King, or somebody who has, and this just turned, doing chest compressions. This just. The way around that is just to bury this. It helps. It does. It's not an absolute, right? That mostly fits in there, but that that's the EMS
Quick stop.
Projectile quick stop, right? Projectile spray quick stop right there. So just stick that in there. As a little extra safety measure. I think that's all I want to say about the suction.
Contrary to belief, when you do get gastric contents from that, it does not mean that you're falsely breathing adequately for the patient. It doesn't. You are, again, you're in the esophagus.
Correct.
That's why it's happening, but you're not ventilating the belly.
Correct. Right.
So as you ventilate that, you're still going to get some air moving into the belly.
Somehow I messed up. I'm not getting it, so they pulled it back out. I was like, no. It's good.
Yeah, and the constant out in typically is where you see the cuff getting ripped, or on that initial push, you'll blow the balloon just because you run across their teeth, like you said.
Yeah, so you're saying that you've had some situations where they saw vomit coming out
and
of here.
they figured it was misplaced.
Yeah, so if there's vomit coming out of here without evidence of aspiration, well, it's actually tough to do with this, but nothing's impossible, I guess, right?
Every firefighter medic across the country said, challenge accepted.
Right. So, but let's see. Well, bougie will. That does. I just wanted to put that down there to show that does wind up in the esophagus.
And now you're in the epigastric port, though.
Right. I'm in the epigastric port. I'm not in the tube proper. Right. So this would be in the esophagus. This would, to your point, this is if I got stuff coming up out of here, that's gastric contents. That's coming out of the belly, right? And you can put a suction unit, or a whistle tip in there, much the same way as I did with this bougie.
Ew. What is on that?
Don't ask questions you don't want the answer to. But yeah, that's where that's coming from. Now, alternately, So this has been shown to me. I've never done it, and I don't know that I would take the time to do it. But you can run a.
Allegedly, it works.
Allegedly, it works. Again, I would never take the time to do this. If I had put a King Airway in somebody who was working, it's going to stay there. But
that's something we're going to do in the hospital.
Yeah.
Is if it's a cardiac arrest or whatever, once they're more stabilized, and we're going to switch it out, we are going to do that.
Yep. That's the point I was making is if it's working in the field, let it work in the field.
And we're going to let it work in the ER until the patient's. If I have a working airway, I checked off A, right?
Yeah.
I will go back and once everything is settled down and patient stabilized, and then I can go back and readdress and put an ET tube in. But if I've got a working airway, I've checked off A.
And I'm just using the bougie for its intended use, which is a tube changer, right? We just ran that down there. Now, in this case, this would be in the trachea. We could then remove this and then subsequently slide an endotracheal tube over it. Again, know that that's a thing, but there's really not much call in the pre-hospital space to need to do that, right?
And if I do that in the hospital, I'm going to do that exchange, and then I'm still going to peek. I'm still going to look and do that visual verification that I'm having tube go through the...
Yeah, you're going to justify it a couple different ways. I got CO2. I can see it through it.
Or I could even drop a fiber optic down the middle of the tube and make sure that I'm in the trachea and pull back.
Yeah.
I can see that the time that we might utilize that in the field might be that we put the wrong size tube in to begin with. It might be working, but we're getting a lot of leakage maybe, and then we would swap. But again, I don't really see that happening.
No.
Using this, though, we'll talk about that later when we get to ET tubes.
Okay. Anything else on the King that we needed that we wanted to run through?
You guys want to demonstrate it?
There you go, Ray.
Neutral inline position.
Neutral inline position.
There you go.
Inflate my cuffs.
Chest rise and fall.
It's working.
Well, good. It wasn't embarrassing.
There we go. Look at that. Big thing here is when you're using your syringe, a lot of times when you want to fill, if you just leave it, your syringe is backing off. And a lot of people don't pay attention to that. So to Caleb's point with the leakage part of when I induce air into both of these balloons and I push, if you do not hold before you disconnect and you let go, now all you're doing is losing a bunch of air on your cuff. So that is something you have to pay attention to.
Any cuffed airway.
Correct.
That
Not
is
just
not
this,
exclusive to
but you have to pay attention. A lot of people are just like, all right, they pushed it, they don't think about it, and they start to unhook it, and I lost over half of my inflation of that now. So people have to pay attention to that.
People leave it attached, just forget to detach it, right? And again, you've lost that cuff pressure. Leave that in for 1 second. I want to. It doesn't need air in it. I do want to bring up one other thing. I'm going to show here.
Also, we would lubricate prior to the insertion, but Scott took care of that before the show. So
No.